All right, testing. Good. So let's go ahead and knock out joints. All right, so joints are also known as articulation, and they are places of contact between the bones, bones and cartilage, or bones and teeth. Arthrology is the study of joints, and they are classified by their structure and function. So the structural classes of joints, we can have fibrous joints, cartilaginous joints, or synovial joints. And in fibrous joints, the bones are held together by a dense connective tissue, a fibrous connective tissue, right? Dense connective tissue. Cartilaginous joints are held together by cartilage, or at least joined by cartilage. And then a synovial joint is more complex, but the bones are joined by ligaments, and there's a fluid filled cavity. And inside the cavity, you will find, synovial fluid, which lubricates the joints. And many of the more movable joints are going to be synovial joints. All right, so uh, joints can be synarthroses. All right, if we're classifying by function, they can be synarthroses, which means they are immovable joints, and these can be fibrous or cartilaginous. Right? So fibrous and cartilaginous joints, that classification refers to what sort of the joint itself is made up or how they're joined. A synarthroses, or a synarthrosis singular, is an immovable joint like the joints between the flat bones of the skull, right? Like the sutures. That would be an example of a fibrous synarthrosis. Amphiarthroses are slightly movable joints, and they can be fibrous or cartilaginous. And then diarthroses are going to be freely mobile joints. These are the joints you're probably thinking of when we talk about joints in the body, and that's going to be all synovial joints. Okay. So the range of motion at joints, it ranges from no movement to extensive movement. For instance, we mentioned the ball and socket joint at the shoulder and the hips. That's highly mobile. Compare that to the joints, the sutures between the flat bones of the calvarium or the cranium. There's going to be little to no movement at those joints, and we don't really want them to move, right? Good. So the structure of each joint determines its mobility and its stability. The structure determines the function, in other words. And there's an inverse relationship or a trade-off between mobility and stability. So we mentioned the skull suture joints, they're immobile, but they're very stable. We don't want the joints between the bones of the skull to move. Um, Kind of the whole point of the skull is to stay intact and protect the brain, right? All right, so we see a couple of different joints here. Yes, the bones of the skull are held together by sutures, which are fibrous joints. All right, good. Then we have the interosseous membrane, which has limited mobility. The radius can rotate over the ulna, but the two bones cannot be separated from one another. They can't move away from each other in any way. Only the radius can rotate over the ulna. All right. Um, all right, so that's a fibrous joint. That's another fibrous joint. And then we have synovial joints, such as at the shoulder and the knee. Okay, those are synovial joints, and they are highly mobile. Um, the knee is a hinge joint. It only moves forward and back. It has a relatively great degree of mobility, but it really only moves forward and back. The ball and socket joint, compare that to the hinge joint of the knee. The ball and socket joint of the shoulder can move in something like 360 directions. All right, or at least it can rotate in 360 degrees. All right. So, characteristics of fibrous joints. They are connected by dense, regular connective tissue, and they have no joint cavity. All right, they are immobile or only slightly mobile. And the three most common types are gomphoses, sutures, and syndesmoses. Gomphoses are the joints between either the maxilla or the mandible and the tooth, basically between the tooth socket and the tooth. Gum, you could think gums, right? These joints form the periodontal ligament, which is part of the gums and it holds the tooth in place. The sutures we mentioned hold the flat bones of the skull together. Okay, those are fibrous joints and they are essentially immobile, as are gomphoses. Syndesmoses are sheet-like joints, as we see in the interosseous membrane between the tibia and the fibula, also the radius and the ulna, and they allow some movement. Uh, the there's not a great degree of movement between the tibia and the fibula, but there is a great degree of movement between the radius and the ulna. I can totally rotate my radius over my ulna as I turn my forearm. Okay. If I turn my hand over, I'm rotating the radius over the ulna. So a gomphosis is like a peg in a socket. We see a tooth in the alveolar process here, the alveolar socket here. And okay, so you see down here we have the bone of the mandible. It could also be the maxilla if we were looking at the other side up top. But here we're looking specifically at the mandible. And you can see the bone, you can see the tooth, and in between them is the periodontal ligament, or it's labeled here periodontal membranes. All right. And so that's composed of fibrous connective tissue that runs out of the mandible and inserts into the tooth. And these perforating fibers hold the tooth in place and form the gums. Okay. Or at least part of the gums. They are a part of the gums, not the entire gums. All right. Good, 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 good. Periodontal membrane or periodontal ligament holds the tooth in place in a gomphosis composed of um, dense regular connective tissue. All right. Fibrous connective tissue. Sutures. These are the joints between the flat bones of the skull we mentioned. Here we're looking at the frontal bone and the parietal bone. So this is the what? What suture? That's right, the coronal suture. All right. And good. They have interlocking irregular edges and they function as a synarthrosis, which means they have little to no movement. And again, we'll see perforating fibers running between the two. Okay. And then they will become ossified later in life. This is something we didn't mention. And they'll be called synostoses. And what that means is that here in childhood and early adulthood, we can see there's a joint between the two bones. And actually, over time, these two bones will fuse together. This joint will fuse the two bones together. And this little squiggly line, which marks the location of the suture, will actually disappear. And so if you look at the skull of someone who is, say, 70, 80 years of age, many of the sutures will have disappeared entirely as the bones of the skull have fused together. So if you are a forensic anthropologist or someone just interested in forensics or anything like that, this is another one of those markings that you can use to determine the age of an adult skeleton. All right. Here we see syndesmoses. We mentioned the interosseous membrane between the radius and the ulna in the antebrachium. And it's a fibrous sheet that holds the two bones together, and it allows for some movement. The radius can rotate over the ulna. Oh, that's another mnemonic I use in my classes sometimes. The radius rotates over the ulna. The ulna stays in place, but the radius rotates over. All right, and it allows two long bones to pivot over one another, specifically the radius over the ulna. The ulna is not going to rotate. Only the radius does. All right. The trochlea of the humerus fits into the trochlear notch right here, and that actually holds the ulna in place, keeps it from rotating. The round disc-shaped head of the radius articulates with the rounded So the top of the radius is flat, but it's got a rounded concave surface that articulates with the rounded capitulum of the humerus, which you can see here, and that allows the radius to rotate because it has a concave head that articulates with the rounded capitulum. It can rotate over that axis there. All right, so the cartilaginous joints, they can be composed of hyaline cartilage or fibrocartilage. They are also going to lack a joint cavity. They will not have a joint cavity. Only synovial joints do. And they can be immobile or slightly mobile. And they include two types, which are synchondroses or symphyses. All right, now synchondroses, syn means with, and chondro cartilage. So this is a joint, the OCs, with cartilage. A symphysis or plural symphyses refers to two main joint types. We've got the pubic symphysis, we mentioned in the last unit, which joins the two pubic bones together anteriorly in the pelvis. And then you also have the fibrocartilaginous intervertebral discs. And so the synchondroses are going to be made up of hyaline, and the symphyses will be mostly made up of fibrocartilage. All right, so good. So the bones joined by hyaline cartilage are immobile. These are the synarthroses. You have the epiphyseal plate. That is a cartilaginous synarthrosis. It's also a synchondrosis because it's made with cartilage, specifically with hyaline cartilage. And then you also have the costal cartilages, which attach the costal bones or ribs to the sternum, either directly or indirectly. We should say that. So for ribs 1 through 7, the true ribs, there is a direct connection to the sternum. And for the false ribs, ribs 8, 9, and 10, there is an indirect connection. They connect actually to the cartilage of rib 7, which then connects to the sternum. And then, of course, you remember for ribs 11 and 12, they are technically false ribs, but they also get the special name floating ribs because they don't have any costal cartilage, or at least they may have a little nub of it, but it doesn't attach to anything. So there's no joint there for them, ribs 11 and 12. Rib pairs 11 and 12. All right, so the symphyses, these are the fibrocartilaginous structures we mentioned. The pubic symphysis, we often say that it's a fibrocartilaginous joint, although to be fair, there's a layer of fibrocartilage laterally on each side, and then there's a layer of hyaline at the center. But for the most part, these are fibrocartilaginous joints, the pubic symphysis. And then we also have the intervertebral discs, which support the vertebrae. They absorb shock, they cushion the vertebrae. And of course, as we move around, there is a great deal of physical force being driven down through the body, specifically down through the vertebral column, which supports the entire body. And, well, the entire body above the pelvis, anyway. And they have, if you remember, an outer region made up of fibrocartilage and then a soft inner nucleus called the nucleus pulposus. And when you get the condition known as sciatica, it's frequently, although not always, because the intervertebral disc has herniated and the nucleus pulposus is pushing out of the sidewall. And here we have these foramina, known as the intervertebral foramina, where the nerve roots leave the spinal cord and they run out through the body. And so if this intervertebral disc is herniated and it's bulging out, in other words, that can press on the nerve roots and cause a great deal of pain and discomfort, numbness along the path of, I keep bringing it up, sciatica, the sciatic nerve in the condition of sciatica. All right, costochondritis. Okay, so chondritis is inflammation of the cartilage, and then of course costo refers to the ribs, costal bones. So this is inflammation of the costochondral joints, or the joints linking the costal bones to the sternum. And it results in localized chest pain, as would be expected for inflammation of the costal cartilages. The cause is usually unknown. It can be trauma or infection, and it can be mistaken for a myocardial infarction, also known as a heart attack. Of course, chest pain is a common symptom of a heart attack. Um, yeah, we'll talk about pain in the nervous system unit when we get there. And that's treated with non-steroidal anti-inflammatory drugs, which can reduce inflammation. Also, pain. They treat pain and inflammation, so it's kind of a twofer deal there. All right, so distinguishing features and anatomy of the synovial joints. This is the um, third structural class of joints. We've got the synovial joints, and these are bones separated by a joint cavity, and includes most of the joints in the body. These are going to be the diarthroses, or the freely mobile joints, and all have the same basic features. We have an articular capsule which surrounds the joint and forms a joint cavity. That joint cavity is filled with synovial fluid, and we are going to find articular cartilage on the ends of the two bones in the cavity. And then ligaments, nerves, and blood vessels will be associated with the joint. Ligaments will be used to stabilize the joint, linking bone to bone, and the nerves and blood vessels. Well, the nerves will, of course, detect pain in the joint capsule, and then blood vessels will supply fluid to the cells that produce synovial fluid, because all fluids in the body come originally from blood, right? Um, Good. So here we see a synovial joint, and it is surrounded by the articular capsule or synovial capsule. Okay. There's a thick fibrous layer, and then there's an inner synovial membrane, and the inner synovial membrane is where we find the cells that produce synovial fluid. Okay. Along the ends of these bones, you will find articular cartilage. Okay, and articular cartilage is made up of hyaline cartilage. And so the way this works is we have a tough fibrous outer layer. The inner layer creates synovial fluid. Hyaline cartilage on the articular ends of bones, in other words, articular cartilage, is going to reduce friction between the two bones when they move. Because if these two bones are in contact with each other and they don't have articular cartilage, you're going to see bone rubbing on bone, and that's going to cause friction and then degradation and damage to the bones. However, if you have hyaline cartilage, which is very smooth, that will reduce the friction and reduce pain and inflammation as these two bones rub over one another. We also have synovial fluid in here, which not only cushions the joint and absorbs shock, but it's also going to lubricate the joint and further reduce friction as these two bones move over one another. And so, for at least most of your life, you should be relatively pain-free in your synovial joints. Of course, as we age, the hyaline cartilage can break down, and we will see bone sometimes rubbing on bone. This is a common complaint with the hip joint, and many people need to get a hip replacement surgery because they have lost the articular cartilage. This also sometimes happens in the knee. The knee takes a lot of abuse. It's a very important joint, and it's the only one that we will probably talk about in depth. But the knee, yes, that happens as well. The articular cartilage can wear down, and then you have bone rubbing on bone, and then the problems just get worse from there. All right, so yes, we mentioned there's a double layered joint capsule. The outer fibrous layer is made up of dense connective tissue, and it surrounds, it strengthens the joint. It prevents the bones from being pulled apart. And then you have the inner synovial membrane, which is made up of areolar connective tissue, and it produces the synovial fluid. Then we have the articular cartilage, which is made up of hyaline, and it's on the surface of the bone at a joint. reduces the friction, it acts as a cushion to absorb compression, and it prevents damage to the articulating ends of the bones. However, it lacks a perichondrium. Remember, hyaline cartilage found in other locations will be surrounded by a perichondrium or a layer of connective tissue uh, similar to the periosteum. And then the hyaline cartilage here is going to be avascular, and in fact, actually, hyaline cartilage, mature hyaline cartilage, is pretty much always avascular. It's not going to have its own blood supply. But that's not to say that it goes without nutrients. Of course, if the tissue here were expected to live without nutrients, it wouldn't last very long. It can get them from the synovial fluid. Now, the joint cavity is the space between the articulating bones, and it's lined by the synovial membrane, which secretes the synovial fluid. The synovial fluid is viscous and a little oily, but it lubricates the articular cartilage on the articulating surfaces. It also nourishes and removes waste from the articular cartilage's chondrocytes, and it acts as a shock absorber. All right. Then we have ligaments composed of dense, regular connective tissue. They connect one bone to another. That's the basic definition of a ligament. They are made up of dense, regular connective tissue, and they connect bone to bone. Their function is to stabilize, strengthen, and reinforce the synovial joints. We have extrinsic ligaments, which are physically separate from the joint capsule, and then we have intrinsic ligaments, which are a thickening of the articular capsule. In other words, they are part of the joint capsule, and they include ligaments outside and within the joint capsule. All right, so sensory nerves and blood vessels are also found in the joints. There are a number of blood vessels and sensory nerves in the joints. Of course, the nerves are going to detect pain, and then report on movement and stretch to the central nervous system. Tendons are composed of dense, regular connective tissue. Do you remember what ligaments were made up of? Yes, it was also dense, regular connective tissue. So histologically, they are the same, essentially, except they're not going to be part of the synovial joint, and they attach muscle to bone. Ligaments, on the other hand, may or may not be part of the synovial joint. Tendons will not be. They attach muscle to bone and help stabilize joints. Although really their main function, because they attach muscle to bone, is going to be to apply force to the bone so that we can cause some physical action to take place. Then, I think this is the last structure. We have the bursae. These are the fibrous sac-like structures that contain synovial fluid. They're lined internally by a synovial membrane, and they're found in a lot of synovial joints where bones, ligaments, muscles, skin, or tendons may rub together. They are basically a fibrous sac filled with synovial fluid that serves as a cushion, and it also holds like tendons and ligaments away from the bone outside of the capsule to protect them. They alleviate friction. And so here we can see them. You have the prepatellar bursa in front of the patella. Okay. You have down here a bursa in front of the patellar ligament, and then also one behind it. And these are basically fluid-filled cushions that prevent the tendon or ligament here from being damaged when it moves over either bone or other tissues. All right. And so here is one view of the knee joint. You can see the articular cartilage on the tibia here. Okay, you can see the articular cartilage on the femur. Okay, and then you can see the menisci. These are shock absorbing pads inside the knee compartment. Oh, the menisci, I didn't mention them earlier. They are, well, they're not technically a chondrosis, but they are made of fibrocartilage. So, yeah, they are made of fibrocartilage. They are not a chondrosis. All right. Good, 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 good. So we're good. All right. Other accessory structures. Yeah, you have tendon sheaths, which are elongated bursae. They wrap around the tendons where friction can be excessive, and they're common in the wrist and the ankle. Um, Good, good, good. Then we have fat pads that act as you might expect, protective packing material in the joint periphery on the edges of the joint, and they can fill spaces when the joint shape changes. All right, so here we can see some of those tendon sheaths in the hand. Okay, tendon sheaths in the hand. They surround the tendons and protect them, especially in the hand where motion is common, and protect them from rubbing over muscle, but also bone here in the hand. All right. Yeah, good, good, good. So joints can also be classified by their type of movement. What type of movement is um, possible here? And so you can have a uniaxial joint where we have one axis, the bone moves in just one plane or one axis. You can have a biaxial joint where the bone moves in two planes or axes, or you can have a multi-axial joint where the bone moves in multiple planes or axes. Okay. So a uniaxial joint would be something like a hinge joint, like let's say your the joint between your distal and proximal phalanges in the thumb. You can move the tip of your thumb forward and back, okay, at that joint, but you can't move it in any other directions. If you're moving your thumb left and right, you're doing that at a different joint. You're not doing that at the joint between the proximal and the distal phalanges. Multi-axial joints are easy. Those are things like the ball and socket joints we talked about. Um, yeah, at the shoulder and the hip as well. And then a biaxial joint would be something like the joint between the atlas and the axis, which allows us to make the up down yes motion and the left right no motion. All right, so classes by shape of joint surfaces from least to most mobile. We start with plane joints, where two things are just sliding over one another. Then we have hinge joints, pivot joints, condylar joints, saddle joints, and the ball and socket joints. So at a plane joint, as you might guess from the word plane, the articular surfaces are flat. They are the simplest and least mobile synovial articulations, and they are uniaxial. Axial, they can be, they have limited side-to-side gliding movement in a single plane. Then we have a hinge joint, which has a convex surface within a concave depression. They are also uniaxial, like a hinge on a door that just moves front and back, front and back. And so at the knee, you can move front and back. At the joint between your distal and proximal phalanges and the thumb, it can just move front and back. That's a hinge joint. The pivot joint is where the bone has a rounded surface that fits into a ligament ring. It's also uniaxial, so you can do rotation on a longitudinal axis. So that would be like between the humerus and the radius, where the radius can rotate. Okay. Then we have a condylar joint, where we have an oval convex surface articulating with a concave surface, and it's biaxial. So, uh, yeah, we got the saddle joint. It's going to have a convex and a concave surface that resembles a saddle. That would be, um, mm, well, technically that applies to the trochlea, but the trochlea really doesn't. Doing it here. Yeah, okay. So yeah, the trochlea would allow the ulna to move left and right, wouldn't it? Sorry, you got to do these by feeling them, you know. And I'm feeling this, and I'm actually rotating the humerus when I make that motion. So now the trochlea doesn't count. Ball and socket joints. This is where you have the spherical head that joins the cup-like socket. So that would be the head of the femur and the acetabulum, or the head of the humerus and the glenoid fossa. These are going to be the multiaxial. They're multiaxial joints. They permit the most movement, and you can move in three planes with these joints. You can move them in almost 360 degrees. All right, so gliding motion. Gliding motion is where two opposing surfaces slide back and forth or side to side, and there's only limited movement possible in any direction. So this typically occurs along the plane joints between the carpals or the tarsals. Um, yeah, so the angular motion increases or decreases the degree of an angle between two bones. And there are specific types here: flexion and extension, hyperextension, lateral flexion, abduction and adduction, and then circumduction. So we've got some pictures to go with this here in a second. Just bear with me. I know it's a lot of words that may be hard to picture without seeing it. So flexion is movement in an anterior posterior plane, and it decreases the angle between the bones. Flexion does. Brings the bones closer together. For example, bending the finger. Extension is the opposite. It moves in an anterior to posterior plane, but opposite of flexion, yes, it increases the angle between articulating bones. So straightening your fingers or making a fist. Now, after making a fist, sorry. The easiest example for flexion and extension, I think, is if I tell you to flex your muscles, what are you going to do? Most people are probably going to pull their arms up and flex the bicep, and they do that by forming a right angle between the humerus and the antebrachium, right? So they flex the bicep. All right, if I tell you to flex your muscles, you flex the bicep. But what you've also done is flexed the elbow joint, or performed flexion at the elbow joint, by decreasing the angle from the anatomical position. The arm is a straight line, and so the angle at the elbow is 180 degrees. If you move into a 90-degree position so that you can flex your biceps, you have decreased the angle at the elbow from 180 degrees to 90. And so this is flexion. Now, if I tell you to extend your arm after this, what are you going to do? Well, you're going to straighten your arm out. And when you do that, you increase the degree of the angle from 90 back to 180. So if you're increasing the degree of the angle, you are performing extension. So if I tell you to extend your arm, you're going to straighten it out. And so you kind of, with this joint, with the elbow, you kind of intuitively understand it. Um, you just have to apply the same principles to other joints moving in the anterior and posterior plane. Then we have hyperextension, which is where we go beyond 180 degrees. And so if my arm is straight, it's at 180 degrees. And then if I keep bending it backwards, I've gone beyond 180 degrees and I have hyperextended it. And in some joints, like at the elbow, you can injure yourself by hyperextending the joint. Other joints allow for it. So the example here is glancing up at the ceiling while standing. If I have my neck straight, the angle of the neck is 180 degrees. If I look down, I have decreased the angle and performed flexion at the neck. If I go back to looking straight forward, I have increased the angle at the neck and I've performed extension. If I continue to bend the neck backwards so that I can look up at the ceiling, I have gone beyond 180 degrees and I have performed hyperextension. And then lateral flexion is where the trunk of the body moves in the coronal plane laterally. Basically, um, if I bend to my left or bend to my right, I have performed lateral flexion. flexion, extension, and hyperextension were all in the anterior to posterior plane. Lateral flexion is in the coronal plane. Okay, so here we have pictures. Yes, I look down, I have decreased the angle. Let's say it's 180 degrees when I'm looking straight forward. I look down, I've decreased the angle of the neck to something like, oh, I don't know, 100 degrees. And by decreasing the angle, I have performed flexion. By bringing the head back up, I've performed extension. And by tilting it further back past 180 degrees, I have increased the angle beyond 180. I'm looking up at the ceiling. I have performed hyperextension. At the elbow, if I were to flex my biceps, I would perform flexion and I would decrease the angle. Now, the angle of this arm here, without measuring it, is something like 110 degrees. And when he flexes his bicep, he is decreasing the angle at the elbow to something like 80 degrees. So he's going from 110 to about 80. So decreasing the angle is flexion. Here, all right, he's at about 110, and then he straightens his arm out. He goes to about 180 degrees at the elbow. He has performed extension. If he were to continue pulling his arm back, it's hard to do. The olecranon process of the ulna prevents it. He would perform hyperextension if he pulled his forearm, his antebrachium, back any further. That would actually cause injury at the elbow, whereas it's fine in the neck. We can do it at the wrist too. Arm is straight here. Okay, wrist is straight. That's 180 degrees. Pulling the hand down, we have decreased the angle from 180 to 90. That is flexion. Bring it back up to 180. That's extension. And then increase the angle beyond 180 degrees. That's hyperextension. And that's fine at the wrist as well. Good. So at the knee here, they're indicating the foot, but actually at the knee here, the leg is straight at 180 degrees. And if I bring it back, I have decreased the angle at the knee and I have performed flexion. If I bring my foot forward, I have increased the angle at the knee from I don't know, this is about 100 degrees roughly. Bring it down to 180, the leg is straight again, then I have performed extension by increasing the angle at the knee. And then lastly, we have lateral flexion, which is where you are flexing a joint in the coronal plane. In this case, she is flexing her spine. It's the joints along the spine that allow her to perform lateral flexion. She can also bend at the neck, although that's also bending at the spine, and perform lateral flexion. All right, so two more movements, abduction and adduction. Abduction is where you pull a body part away from the midline, away from the mid-sagittal line, right? And so if my arms are at my side and I bring one up in the coronal plane, then I've performed abduction. If I bring it back toward the midline, then I'm performing adduction, which is the opposite motion. All right, and so you can picture over here, there are aliens trying to abduct her arm, right? They got a tractor beam locked on, they're pulling it away, something like that. She is performing abduction. Bringing her arm away from the midline of the body. Bringing it away, abduction. Bringing it back, adduction. A-D-D, adduction is bringing it back. We can do this at the wrist as well, moving laterally, abduction, away from the midline, moving back toward the midline of the body, which would be over here. That is adduction. This is particularly important in the thigh, especially at the hip. Again, they're indicating the feet here, but the angle we're concerned with is the hip. And so by pulling his leg away from the midline, he is using muscles that act on the hip and performing abduction. Okay, so this would be like the gluteus medius, the gluteus maximus, pulling the leg away. And then in the inner thigh, we have muscles called the hip adductors, and they're going to act to pull the leg back toward the midline, and that process is called adduction, bringing it back toward the midline. All right. We can also do this within the hand. Spread the fingers out. That's abduction away from the midline. Bringing them back together is adduction, bringing them back toward the midline. Now, circumduction is where we can sort of spin the arm or the leg around at a ball and socket joint. Only ball and socket joints can do this, so that would be the shoulder and the hip. And this is where we can sort of spin it in a kind of circular motion here. Kind of if you've ever, as a kid, pretended you were like a windmill or something, just whipping your arms around in a circular motion. That's circumduction. So the distal end makes a circular motion. Of course, the proximal end stays stationary. Uh, the movement makes an imaginary cone shape. So you can think about drawing a circle on a blackboard. That is circumduction. If you were to hold the marker up and then draw a circle, that is circumduction. You can do the same thing with your leg too at the hip joint, or your lower limb, I really should say, at the hip joint. All right, so rotation. This is where, excuse me, this is where a bone pivots on its own longitudinal axis. Okay, and we have lateral rotation, where we turn the anterior surface of the bone laterally. Medial rotation, where we turn the anterior surface of the bone medially. Pronation, which is where medial rotation of the forearm turns so that the palm of the hand is posterior. Okay, and then we have supination, which is the other, where we bring the palm of the hand up. And we have a picture of that here. Rotation at the neck, we can turn left and right. Lateral rotation here for the forearm is bringing it sort of toward the front of the body or back away from the body. Lateral rotation away, medial rotation, rotating it medially. And what we're actually rotating here is not the forearm, but the humerus. The humerus is the one rotating in this instance. Uh, Good. So over here we have lateral rotation where we can, it looks like we're rotating the foot. Of course, the foot does turn, but what we're actually rotating is the tibia. Okay, well, no, more the fibula rotating along its longitudinal axis. Basically, it's there, and along its length, it just turns. All right, and then we have pronation and supination, which is where we basically turn the palm of the hand up or the palm of the hand down. Now, visually, we're looking at the hand, but actually what's rotating is the radius, okay? So in pronation, from the anatomical position, the radius has rotated medially, and the end result is that the posterior surface of the hand is now anterior. The posterior surface of the hand is now in front. The opposite action is where we turn the forearm so that now the palm of the hand is facing forward as we would in the anatomical position. So turning the forearm so that the palm of the hand is facing forward is supination. And there is a little mnemonic trick there. If you were to hold a bowl of soup in your hands, you would be performing supination, right? To turn your palms up so that you can hold a bowl of soup is supination. Just remember the opposite of that is pronation, where we turn our palms down. And again, visually, we're looking at the hand. It helps us memorize this motion, but understand, of course, it's the radius that's rotating, not really the hand. I mean, the hand does turn, but it's being moved by the radius. the radius is rotating along its longitudinal axis. All right, special movements. These do not readily fit other categories. We have depression and elevation. And this is where we move, in the case of depression, inferiorly with a body part, or superiorly in the case of elevation. It's where we bring a body part down or up. So with the mandible, it's easy to bring the mandible down when we open the mouth. That's depression. And when we elevate this bone, it is, elevation. When we bring it up, close the mouth, that is elevation. All right. We can also do this with the shoulders. You can depress the shoulders, make them drop, and you can lift the shoulders as well. And you can do this with the clavicles too. You can lift and lower or elevate and depress the clavicles. This is movement in the vertical plane. Elevation and depression. Next up, we have dorsiflexion. This is where we are, this is a limited motion of the ankle joint. It's where we are pulling the foot back. Think dorsal back, right? So dorsiflexion is where we pull the foot back at the ankle joint. Plantar flexion is the opposite, and this is where we are flexing the foot down, okay? The plantar surface is on the bottom of the foot, okay? And so you can think plantar flexion, we are flexing the plantar region. All right, dorsiflexion, think dorsal back. It's where we're pulling the foot back at the ankle. Then we have eversion and inversion, and this is where we rotate the foot out for eversion, and then we rotate it in for inversion. So if you can remember that, in, I'm turning my ankle really so that the sole of the foot faces in. That's inversion. If I turn my ankle such that the bottom of the foot faces out, that is eversion. All right, now protraction and retraction is where we move a body part either anteriorly or posteriorly in the anterior and posterior plane. So we can do this with the jaw. We can jut it out, stick it out, and perform protraction. Or opposite of that, we can bring it back into place, and that is retraction, where we pull it back. So opposition is the movement of a thumb towards the tips of fingers at a carpo-metacarpal joint. And this enables the thumb to grasp objects. All right. Another name for our thumb, or at least a common phrase describing our thumb, is it's an opposable thumb. Not all species have opposable thumbs, and only species that have opposable thumbs are able to perform opposition and grasp things. Now, reposition would be the opposite, where we are moving the thumb away from the tips of the other fingers and opening the palm back up. All right, so the knee joint, all right, is the largest and most complex diarthrosis. All right, largest and most complex freely movable joint. It's primarily a hinge joint, as we said. It's capable of some slight rotation and lateral gliding when it's flexed. It's composed of two separate articulations. We have the tibiofemoral joint between the tibia and the femur, and then also the patellofemoral joint, the joint between the patella and the patellar surface of the femur. The patellar surface was between the two condyles of the femur. All right, and so here we see the quadriceps muscles. There are 4 muscles making up the quadriceps femoris muscle group. Here we can see 1, 2, 3 of them. There's a 4th one that's deep right here. Okay, and we'll cover those when we get to the muscle unit, but they all converge on the quadriceps femoris tendon. All right, and then the quadriceps femoris tendon, it runs down, and embedded in it is the patella. Now the patella is a sesamoid bone. Remember, that's a bone that is embedded in a tendon or ligament. It's the largest sesamoid bone in the body, and unlike other sesamoid bones where they're variable whether or not they're there, everybody for the most part has a patella. It would be unusual to not have one. Then down beyond the patella is the patellar ligament. So the patellar ligament attaches the patella to the tibial tuberosity of the tibia, and the quadriceps femoris tendon connects the quadriceps femoris muscles to the patella. Now, technically, this is all one structure passing all the way through, but the region between the muscle and the patella could be referred to as the quadriceps tendon, and beyond that, the patellar ligament connecting the patella to the tibia. Because remember that muscle is connected to bone by a tendon, and ligaments connect bone to bone. All right. All right, good, 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 good. So we've got more to talk about. We have the fibular or lateral and the tibial or medial collateral ligaments. Collateral means, excuse me, my back, to the side. All right, these are on the outside and they're on the sides, okay, of the joint capsule. They are extrinsic ligaments. And good. So fibular and tibial tell you which bones they attach to, the tibia or the fibula. They're also called the medial or lateral collateral ligaments, which also tells you where they are. Medial and collateral is maybe a better name for it, but the tibial will be on the medial side, and the fibular ligament will be on the fibular side. All right, good. Once we are inside, we've cut away the gastrocnemius here. We see the oblique popliteal ligament. Remember, the popliteal region is the region posterior to the knee, right? All right, so we see the oblique popliteal ligament. Oblique means running at an angle, okay? And other than that, we see pretty much the same ligaments here. Uh, good. Now, inside the joint capsule, we have the ACL and the PCL. ACL stands for anterior cruciate ligament. PCL stands for posterior cruciate ligament. Here's an anterior view of the knee joint, and then over here on the right is a posterior view. Okay. ACL, just about everybody's heard of. Athletes are commonly injuring their ACL or anterior cruciate ligament. The word cruciate means relating to a cross, and so these two ligaments are crossed over one another. They form sort of an X shape inside of the knee. The anterior cruciate ligament happens to be the one in front, right? The anterior one. And then the posterior one, the one in back, is the PCL or posterior cruciate ligament. And both of these actually can be injured through, sports accidents and whatnot. Hyperextension frequently will damage the anterior cruciate ligament. Yeah, so it's more common to damage the ACL than the PCL. And you would typically injure it due to hyperextension at the knee. All right, good, good, good. So I'm pretty happy we've covered a lot of this. The menisci, there are two in each knee joint. There's a medial meniscus and a lateral meniscus. And if you're looking at this picture and you're like, which one's which, remember the fibula is going to be lateral. All right, so if you can see the fibula here, then you know this is the lateral meniscus, and over here the medial meniscus. All right, so I'm actually pretty happy with how we covered that. If you want to read these slides, it's a video. You can always pause it uh, and take a look at them. So, clinical view, we're looking at knee ligament and cartilage injuries. The tibial collateral ligament injury occurs when the leg is forcibly abducted. Basically, the lower leg, the leg proper, is forced to move laterally, maybe against its will, right? the rest of the leg is staying medial, but the rest of the, let's say the thigh is staying medial, but the leg proper, the lower leg, is moving laterally. And that's going to tear the tibial collateral ligament. The fibular collateral ligament occurs when the medial side of the knee is struck. Basically, the same thing could happen in the other direction as well, though. The thigh could move laterally, whereas the lower leg could move medially. ACL injury occurs when the leg is hyperextended. PCL, posterior cruciate ligament, injury occurs when the leg is hyperflexed, although really you're far more likely to experience hyperextension. And so ACL injuries are more common. Meniscus injury occurs due to trauma and or overuse, or with age they do break down over time and may need to be replaced or injected or any number of other treatments. The unhappy triad is an injury of the tibial collateral ligament, the medial meniscus, and the ACL, and it occurs due to a lateral blow to the knee that abducts and laterally rotates the leg. All right, so arthritis is a rheumatic disease that involves damage to the articular cartilage. Okay, actually, there are two types, we should say. There is a rheumatic disease that involves damage to the articular cartilage, and then there's osteoarthritis, which is primarily a problem of aging in the joint due to wear and tear. Rheumatic disease, in other words, is an autoinflammatory disease. And so that involves inflammation and the immune system. Osteoarthritis, on the other hand, is not actually inflammation. The name means inflammation of the bones and joints, but it's actually not a form of inflammation. Does not involve the immune system. It actually involves pain due to the breaking down and the wearing away of the articular cartilage and the bone in a joint. So kind of a misnomer there. Osteoarthritis is the most common form of arthritis. Rheumatic arthritis affects roughly 1% of the population, which is like a lot of people, but not nearly as many as osteoarthritis. Like 1% of the population is a lot. In the United States, which has a population of 330 million, that means that 3.3 million people will develop osteoarthritis. That's a lot of people. Not osteoarthritis, sorry, rheumatic arthritis. Sorry, I'm always recording these lectures so late at night, always, so it's the end of the day. All right, exercise and joint health. So this will increase the flow of synovial fluid to the chondrocytes. Remember, the chondrocytes in a synovial joint are avascular, and so their nutrition is coming in the synovial fluid. They also get rid of their waste in the synovial fluid, and so exercise will increase the flow of synovial fluid, bringing nutrients in and carrying waste away from the chondrocytes, which are entirely dependent on the synovial fluid in the joint capsule. This will exercise will strengthen muscles that support and stabilize joints. And then in the extreme, it may aggravate potential joint problems and may worsen osteoarthritis. There is a lot of concern among certain people, mainly non-runners, that running is bad for your joints. And, for the most part, running is good for your joints when done reasonably, when you are not doing very stupid things. Running is good for you, and running is good for your joints and can strengthen them and maintain your health into old age. My father is a ultra marathoner, or was. He recently had to have his hip replaced. He's not allowed to run anymore, but that's really unfortunate. He loved running, but he would do ultra marathons, which are things longer than a marathon, and he would do 24-hour races where you run for basically 24 hours on a track. You're just on a track running for 24 hours. I mean, that's insane. People are not meant to do that. He would do, 60, 80, 100-mile races. You're not meant to do that. At least not your entire life. You can do it a couple times, but not your entire life. That is extreme, and that will wear down the cartilage and other structures around your joints. So arthritis just moving on, we're looking at arthritis here, is a group of inflammatory or degenerative diseases of the joints. The symptoms include joint swelling, pain, and stiffness. You can have gouty arthritis, which is seen in some middle-aged and older males, and it's due to increased levels of uric acid. The uric acid forms crystals in a joint, commonly in the big toe, the hallux, joints located in the hallux, and it can be incredibly painful. So. That can be fixed with changes in diet sometimes, also medication. Although I did know one person who was taking, and I can't remember the name of it, but it was a medication for high cholesterol, and a side effect of that medication was increased uric acid production, which led to gout. So something to watch out with certain cholesterol medications as well. Osteoarthritis, we mentioned, is a degenerative joint condition seen in older individuals. Just basically over time, your joints wear down. And exercise is not necessarily responsible for this. If you exercise, you can actually promote the health of your joints. Remember, we said that exercise increases the flow of synovial fluid, and the articular cartilage is actually dependent on that flow of synovial fluid. So exercise can actually improve that flow, maintain the cartilage, and prevent osteoarthritis. Okay. Fingers, knuckles, hips, knees, and shoulders are most affected with osteoarthritis. And then we mentioned rheumatoid arthritis. It is an autoimmune or autoinflammatory disease. It's seen in younger to middle-aged adults, usually women, and it starts with synovial membrane inflammation. You can treat it with anti-inflammatories. They're not very effective, though. In the old days, you may, if the rheumatoid arthritis were severe enough, you may have to ablate or destroy the bone marrow and get a bone marrow biopsy because, again, it's an autoimmune disorder. So the bone marrow is producing blood cells, white blood cells that will attack your joints. So you destroy your own bone marrow and then get a transplant. That was the extreme case treatment in the old days. Now they have anti-rheumatic drugs, and a common one is adalimumab, or brand name is Humira, and it can actually target some of the inflammatory molecules involved in this process and knock them out. Kind of an expensive drug, but it works wonders for most people who take it. All right, so that's the end of the joints lecture. Thanks for tuning in, and if you have any questions, feel free to email me. I'll be glad to answer them.